Can you see where is the presentation? I hope all of you can see the presentation.
Yes, please, we can see.
Can you turn it on presenter's view? That it appear on the screen?
Yeah, Dr. Tandon, we can see the presentation.
No, it's all right. I mean, if it is on the presenter's view, it would be a lot more bigger. Otherwise, it's fine.
So this is the topic of the today's presentation, Pandemic Coronavirus Disease 2019. And the unseen and unsaid, without going into the words, it's quite evident that why we have selected this topic for today's presentation. Before I go to this wonderful journey of COVID-19, and when I say wonderful, because it has taught us a lot of things which we never thought of in last 20th century and even in 21st century. So that's why I always use this a wonderful journey which I'm going to take you. Before I go into, I'm sure all of you might have seen this movie called Three Idiots. And all of you might have been quite aware with this person whose name students used to say virus. And this movie is so close to us because when this movie was actually thought of at that time, IIM Ahmedabad and CCMB, we were doing a lot of things together, and this nomenclature, the virus, actually came from there, and that's how we decided that, because whatever name we were deciding for a faculty, each and everything was available onto the Google. So the problem for us was that we were not willing to offend somebody, but also to give some name which is actually more acceptable among the youth. And today, you know, anything which becomes more popular, the people say that become viral. Whether it's a movie, whether it's a video, whether it's a trend or fashion or song or anything that becomes viral. So the viral is not being taken as a negative word nowadays, but also taken as a lot of positive words. So with this, let's go to the main presentation of today. And before we go to this presentation, you know that the presentation word which we are going to use today is on SARS-CoV-2, which is the virus which causes the COVID-19. But before this, you might have seen a lot of names coming almost every day in the newspaper, and that has created a big confusion initially that what name is the correct name. As we always say, that we do not have a baby book of the names which helps us to select a name. But there have been international ways by which we do, and there is an International Committee on Taxonomy of Virus called ICTV, for which I'm also one of the members, that decides the name based on the phylogeny, taxonomy, and various established practices, which eventually gives the name. And based on that, the virus name has been given as severe acute respiratory syndrome, which is the disease caused by the coronavirus 2. So that's how the name came as SARS-CoV-2, which causes the COVID-19. But before this, a lot of names which you can see here: Wuhan virus, novel coronavirus, 2019 COVID-19 virus, pandemic coronavirus, and others have been given, and still we keep on seeing. Even some people are writing C19 virus, some are writing K19 virus, and a lot of those things are happening. But the official name of the virus is SARS-CoV-2, as it is mentioned here at the bottom of this slide, and the disease is COVID-19. So what is this COVID-19? COVID-19 is an infectious disease caused by a newly discovered novel coronavirus. And this virus is new because we have not seen this kind of virus in the human beings earlier. We have seen coronaviruses from 1937 onwards, but normally they cause infections in the animals, and very, very few or rare instance have been known in the human infections. That's true from 1963 onwards, and that's how the name of couple of coronaviruses which have been seen in the human beings have been given, like 229E, NL63, OC43, HKU1, and they are normally, whenever we see the coronavirus associated infections in the humans, they are the normal ones which we have seen, but they do not cause any severe illness, and most of the times they themselves get eradicated, and there's no need of any treatment or any kind of a diagnosis separately required for these viruses. Patients with COVID-19 are evaluated separately. There's a different protocol and SOPs for the diagnosis, and there's a different protocol for the treatment also. So that's why this particular virus is very different. In 21st century, we have seen only 3 coronavirus infections. One is the SARS-CoV, which we have seen in 2002 and 3. We have seen the second, that is the MERS, which we have seen around 2013. And now we are facing this COVID-19, which is another cousin of the previous SARS virus. Now let's look into the history that how these viruses have evolved. And these are some of the world's worst pandemics which we have seen in last 2000 years almost. You can see it starts with Antonian plague, then we have several plague infections throughout, including the bubonic plague, smallpox. We have seen even the 17th century Great plagues. We have seen the 18th century plagues which has killed around 600,000 people. And very importantly, we have seen Spanish flu, Russian flu, and HIV and AIDS, which we have seen in our time periods, around 25 to 35 million people have been killed. Asian flu, Hong Kong flu, MERS, Ebola, SARS, swine flu, COVID, and Nipah also, which we have very recently seen. But we were very able to contain them in a very shortest possible time. So that was one of the biggest achievement also for us. If you look in terms of deaths, the bubonic plague, which we have seen in 1347 to 1351, you can see almost the years also. A lot of people ask me that how much time it will take to disappear this COVID-19. So you can see how much time these infections have taken, which we have seen in the past, has killed around 200 million people. The smallpox has killed around 56 million people. The Spanish flu around 40 to 50 million people. The plague of Justinian has killed again 30 to 50 million people. And then there's a lot of mortality from HIV and AIDS, and several of them which you can see here, including Russian flu. Very recently, we have seen Ebola, swine flu, MERS, SARS, and COVID-19, which is still we are counting that how many cases and deaths we are getting almost every day. Now, if you look in terms of case fatality rate, the Nipah has topped among all of them, but the good thing was it was reported only in 2 countries. But if you see, Ebola has 40.4% case fatality rate, whereas SARS has 9.6% and MERS has 34.4%. But when we come to the COVID, although the mortality is around 3.9%, but this has been known now by more than 200 countries. So you can see the prospect of the disease, and you also see that if the denominator, that means the number of countries, if that increases, the percentage case fatality rate goes down. So there are a couple of factors when we do the stats in studying the case fatality in these cases. This is also one of the indicators that how the severe the disease is. Now, as you know, we are seeing there's a lot of sequencing work is going on. This coronavirus is primarily of 3 types, A, B, and C. The type A is closest to the coronavirus, that is found in bats and pangolins, and this is considered the root of the outbreak. There have been 2 subclusters, one linked to the Wuhan and one linked to the America and Australia has been reported with this. This A subtype with just small mutation changes to type B, and that is most common in Wuhan and derived from the type A via 2 mutations, and this mutates slowly in China, but not rapidly outside China. And that's why, if now we see the mortality compared to the rest of the world in China, that has been pretty low. Now, if you go to this subtype B, that again mutates with another further mutation and changes into subtype C, and this subtype C is the daughter of type B. This spreads to Europe via Singapore. In India, there is a lot of sequencing analysis has been done, and what we are finding is that subtype A, and within the A, we are getting A2A subtype, that is the most prevalent subtype found in India. What is the basic difference between this pandemic COVID-19 and when we are getting seasonal flu? Because a lot of symptoms are quite overlapping with the seasonal flu and the COVID-19. So the seasonal flu occurs almost every year, but as you see, this pandemic COVID-19 we have seen rarely. In 21st century, we have just seen 3 coronavirus infections, which I just mentioned. The type of flu which people get in seasonal influenza, they are normally having immunity against that. So we normally say it's a viral fever, take rest and drink plenty of water and you will be fine. But here, it is a worldwide outbreak for which no, or even the healthy people do not have any kind of immunity. So seasonal influenza, normally the healthy people who are not immunocompromised, they do not get this kind of disease. But for pandemic influenza, most of the patients, even if they are healthy, I'll come to those slides also, they are also getting disease. So nobody is spared that I am healthy and I will not get the disease. For seasonal influenza, now we have the vaccine available, which is tetravalent vaccine. But for the pandemic influenza, there's no vaccine available till date. Now, how the virus looks like. So these are some of the pictures when the virus is cultured in the laboratory. You can see here, these are the T lymphocytes where the virus is actually growing, and they have been multicolored staining has been done with the help of the different type of microscopy, indirect immunofluorescence microscopy, which we say, and that gives the fluorescence. So you can see a very unique corona-like structure. Corona means the rays of the sun. So you can see the sun rays kind of structure onto the surface, and inside there is a very clear-cut matrix and envelope. So you can see it's very nicely shown onto the surface, this corona-like structure. And this is here one of the CD4 cells. When the virus matures, you can see how it looks like. Let's see this structure in a little more detail. So this is the way the virus structure looks like. If I do the transverse section of this, you can see on the surface there is a spike glycoprotein that is also known as protein Guy. And this is the most important protein because this helps in the attachment of the virus. Then there is the M protein here, and then there is a hemagglutinin esterase dimer that is also known as HE, which is found somewhere in between. And then there is an envelope. So that's why the RNA inside is very nicely protected. Then there is an RNA, and this RNA is also protected in a tube-like structure called nucleoprotein, that is N protein, and these are the envelope proteins. So that's how the virus looks like. This virus has been classified under Coronaviridae family. So corona means the rays of the sun, as I said, and viridae means the family. So the family of the viruses which have a sun rays kind of a structure, they are known as Coronaviridae. They are basically of 3 types, alpha, beta, and gamma. That's purely based upon the sequencing data. And so this has been classified as a beta coronavirus. And within the beta coronavirus, very recently they have been classified into the subgenus called cerbicovirus. Cerbicovirus means severe acute respiratory, beta, BE, COV means coronavirus. So in virology, one good thing is that if you understand the nomenclature, then you don't have to actually learn it by heart. You just, by looking onto the name, you can find out which kind of virus I am dealing with. Now, this is the structure which was actually given by us in a very early stage in the month of February itself, when nothing was known about this virus. And this spike structure was actually solved by us in January itself that has been published later on in the Virus Disease Journal from Springer Nature. So what we have seen is that there is a spike glycoprotein, and why I'm every time emphasizing the spike glycoprotein, because this is the glycoprotein which mediates the interaction with the cell surface receptor called ACE2, and the ACE2 is mostly found in our nasal and pharyngeal tract. So when somebody gets immediately, it's get attached with that ACE2, and that's how it get internalized. Then, as I showed you in the previous slide, there's an envelope, nucleocapsid protein, there is an RNA inside, and then there's a membrane. So that's how you look like. You won't believe the couple of people, when they have seen this picture, they said, this looks like to me a print, and why don't we get it printed on our shirt or any embroidery? I said, you're most welcome if you want to do that, but you don't know that this is the structure of SARS-CoV-2. So this was the very initial stages in the month of January when we have started, when even India has not seen even a single case. So the genome of this virus ranges from 26 to 32 kb, which has around 6 to 11 open reading frame. And you can see these are the open reading frame here. ORF1 A is the biggest one, which encompasses around 67% of the genome, and that encodes for 16 non-structural proteins, whereas the remaining ORF encodes for structural and accessory proteins, which you can see here. The non-structural proteins includes 2 viral cysteine proteases, including papain-like proteases like NSP3, chymotrypsin-like proteases, 3C-like proteases, which have been very widely used earlier also for making the antiviral drugs, and main protease, which is NSP5. The people are also trying this for making the drugs for the antiviral activity. Then we have RNA-dependent RNA polymerase, that is NSP12, and that is a very unique in this virus. Because of that, the chances of errors are very less, and that's why you might have seen when the A virus is changing to B virus, there's just 2 mutations. When the B virus is changing to the C virus, only just 1 mutation, because this RNA-dependent RNA polymerase is able to actually do the correction automatically whenever the virus mutates. Then there is a helicase, which is NSP13, and there are the others likely to be involved in the transcription and the replication of SARS-CoV-2. And in addition to these NSPs, the genome encodes for 4 major structural proteins like a spike glycoprotein, there's a membrane protein, there's a nucleocapsid protein, that is N, that is envelope protein called E, and there are accessory proteins like open reading frames or ORFs. So everything is actually responsible for the genome, because the genome is a segmented genome, and that's why it is very important to understand that how all the genome is actually replicating, and then after replication everything going in the same order so that there is no defect when the new virion is made. So how the virus actually originated and how this evolution of this virus is going on, you might have already seen this in so many newspapers and otherwise, that the SARS-CoV-2, which we have seen in 2002 and 3, the natural host was bats and the intermediate hosts were pangolin. While the MERS-CoV, which we have seen in 2012 and 13, the original host was bats and the intermediate hosts were camel. But for this 2019 nCoV, now which we say COVID-19 or SARS-CoV-2 virus, we still do not know the intermediate host, although the natural host is still believed to be the bat, because that data came from the sequencing, which we have also done, and I'll come to that slide also. And all of them are known to cause human-to-human transmission. But how this happens other than aerosol, we still do not know. Now, this is the work which we have done, and I think this is one of the most pioneer work from India published in the Springer Nature's Virus Disease, where we have taken the 2 samples from the China itself, from the Wuhan seafood market, and the sequencing of the spike glycoprotein suggested that it is very close to the bat SARS-like coronavirus, which was isolated earlier from the bats, but this was also very much close to the previous SARS virus. We have also taken some outgrowths from the flavivirus just to make sure that there is no lab contamination in this particular data. So what we have found that there was around almost 87% similarity in the SARS-CoV virus, which is 2002, and this 2019 nCoV in the spike glycoprotein, which you can see here. Out of this, the maximum change was around 25.6% in this RBD domain of this spike glycoprotein, and this is the way exactly the virus looks like when we are doing the biophysical characterization. So this is the work done from our laboratory, which is now published. Now, what we have also studied, that if the virus is new, then is there any change in the attachment of the virus? This activity is called glycosylation. That means the attachment of the glucose moiety onto the host cell membrane. So how this happens, we have gone through to study the whole glycan receptors and how this binds. And what we have found, that there was a significant difference in the N-glycosylation sites. I will come in a second in the next picture. But the importance of this work was, this work has given us the first insights that what monoclonal antibodies can be used so that we can neutralize, and we have done that also. We have also done that how this glycosylation can be blocked. So the first line of defense for the therapeutics which we have developed. We have also looked for the lectins which can actually help in the binding so that the response favoring the host antigen presentation can be taken care of, and the response favoring the virus attachment and entry can be taken care of. All this work which we have done, I will be presenting in just few slides. So you can see here, this is the N-glycosylation pattern. And you can see here, this is the 2019 COVID-19, and this is the SARS-CoV virus. And if you see here, this particular site was missing, which was actually present in 29 virus. So considering this, it was very important for us to understand that what these glycosylation sites have the message inside. And what we have found, that this glycosylation was actually mimicking the previous glycosylation. That means that the virus, it's like a terrorist entering in your office, utilizing your own identity card with a fake mask, as well as it's also going in your office and showing that, see, I'm your own. So that's how this has given the false perception to our CD4 and CD8 cells, and that's how this has gone to the to our cells. And recently there's a paper in Nature Medicine which has also proven the same thing with what we have shown, that how these glycosylation small sequences actually gave the false perception to the T lymphocytes so that they can get confused and they're not able to differentiate that what is self and what is not the self, and you get the infection from anyone who is positive. Then we looked for the antigenicity, and you see when the virus was significantly different, the most obvious thing was that the virus should also have the significant difference in the antigenicity. And we found that, see, most of the sequences you can see throughout were significantly different. And this is the 2002 SARS-CoV and this is the 2009. We have done this and validated with various other ways also, and the data hasn't been changed even with the various databases also we have checked in. So this is the way we found that why the virus is highly mutagenic and why the virus is highly virulent. And we also tried to see that how this difference actually translates into the structure of this spike glycoprotein. Spike glycoprotein is very important because 80% of the world research is going on around this particular structure, because this is the protein which helps not only neutralizing antibodies, but also to help us in how to block the attachment of the virus in the cells. So you can see here, this is the 2019 nCoV, and then we have also seen that we have SARS-CoV. So considering all this, when we have matched it, what we have found, and this structure was done at 1.39 angstrom. Now, very recently, the science has done a whole crystal structure of this, but this was the first structure in my knowledge, at the globe solved by us at KGMU Lucknow. So this spike structure, the science paper which they have done, the crystal structure also is 99.9% same with that particular structure. And this was done at 1.39 angstrom. What we have found that the structure was overlapping with the previous SARS-CoV virus, suggesting that in spite of the significant difference in the sequencing data, in the RBD domain, and as well as in the antigenicity, there is not significant difference in the structure of the virus, suggesting that the previously known antibodies might work. And a lot of people are working on this. Recently, the Lancet paper has taken this data and they developed the vaccine. Even the new vaccine which you are seeing from AstraZeneca has also used this sequence which we have shown in the previous slide to make the antibodies for monoclonal, and that's what is given in the first vaccine which has been tried in China as well as in England. So that's the beauty of this particular structure, and we feel really happy that this work has been done at KGMU Lucknow. So collectively, for the first time, our results exhibited the emergence of the human SARS-CoV virus, which is closely related to its predecessor SARS-CoV, which we have seen almost 18 years back. Foremost, our data provided the evidence that 2009 nCoV uses the various novel glycosylation sites as SARS-CoV and may have a potential to become pandemic owing its antigenic discrepancy. This statement was said on 24th Jan, and you won't believe the WHO has accepted on 11th of March. So you see all this thing which I'm mentioning here was said on 24th Jan, and later on each and everything has been taken in consideration, and now all of them are true. Now further demonstration of the novel CTL epitopes may impart opportunities for the development of peptide-based vaccine for the prevention of the 2019 nCoV, and additionally our revolution of the similar antigenic sites in both 2019 nCoV and SARS coronavirus suggests the scope of the SARS-associated peptide-based vaccine for the prevention of 2019 nCoV. And as I said, the two vaccines are already there, which have used the sequences which we have mentioned in the previous slides. The similarity in the spike glycoprotein structure also suggested the use of coronavirus-specific attachment inhibitor as the current choice of therapy. And at that time, only one inhibitor was known, and that was hydroxychloroquine. Government of India is still using hydroxychloroquine as one of the important attachment inhibitor from this work. We haven't said deliberately because that was a company-specific thing, but now everybody knows that has been developed by KGMU also in a further chain of anti-therapeutics. Now let's look into the epidemiology. As we all know, China has alerted WHO on December 31st. When the whole world was celebrating the new year, we all were busy, even at KGMU Lucknow, to find out that what we can do when we came to know that some unique pneumonia-like cases have been seen in China. On Jan 7, WHO officials announced that they have identified a new virus named SARS-CoV-2 that causes COVID-19, and it belongs to coronavirus family, which includes the previous members like SARS, MERS, and the common cold. And then Jan 11, China announced the first death linked to COVID-19. By this time, we have already done a lot of work at KGMU Lucknow also. Jan 13 was WHO reports first case outside the China in Thailand, and in February 26, NIH began the clinical trial of the US for a potential COVID-19 treatment called remdesivir, which is now accepted for the human uses. Now, February 29, the FDA took steps to expand the novel coronavirus testing to the hospital clinical microbiology laboratories. By March 11, if you remember, we had Holi on 9th of March this year. WHO declared COVID-19 as a pandemic with more than 100,000 cases and 4,000 deaths in 114 countries by that time. On April 2, confirmed cases of COVID-19 topped 1 million worldwide, and the journey still continues. And we are now seeing a huge number of cases and deaths worldwide. If you just see, because we are still believing that most of the world's countries got the cases because of the international travel. If you see from December 3 to Feb 3, the world travel is still limited to quite a few. But if you see Feb 21 to April 21, almost nothing was left in the world where the cases have not reached, suggesting that how important it was to take care of the international travel when we are actually handling these kind of infections. Now, if you see the total number of cases and deaths worldwide, this is the picture on 22nd of July of this month. That is 14.92 million cases we have seen by now, with around 0.6 million deaths worldwide. In India also, we have seen around 1.19 million cases and more than 28,000 deaths till date. If you see this picture, we are in the world tally at number 3. I would have been very happy if this would have been the Olympic this year and we would have been at this position. But this is very unfortunate that we are in number 3, and this is not the good sign for any country like India. But if you see that 1 million population, the cases per million population, we have done still significantly well. And not a lot of people are asking whether the lockdown actually worked. Yes, that worked. Because of that, this number is still down. If you see the deaths per 1 million population is still in India around 20, and the tests have been significantly increased. We are doing almost 14 lakh cases tests almost every day. So that's a huge data for us to see that how India is actually handling in compared to several other countries in a much better scenario. Now, if you see, some of the states have a little higher number of cases. You can see here the Maharashtra has almost the highest, and a couple of more also. And the reason is still not known, but it is believed that either the lockdown was not properly done, or the people are still not following the basic understanding of the safety measures, like keeping one arm distance, using the mask, and all those kind of things which have to be done for mitigating the disease. Now, if you see in India, almost the major burden is only 35% of active cases. However, the 63.33% cases have been successfully discharged, and the death rate is 2.55% in India. If you see, most of the cases are in the age group of 20 to 49, that is around 59%. And it was believed that the senior citizens and children less than 5 years of age are at the higher risk. Yes, they are, but this is the age group which is the most negligent about the common practices of the safeguard to their own health. And that's why they are becoming positive. They are going to the multiple places, market, shops. You can go and you see that how this younger generation is actually not listening the basic guidelines given by the government of India. 50 to 69, we have around 25% of the cases. In cases more than or almost 70 age, around 5%, and 0 to 19 years, we have 11% of the cases. If you see, most of the, or you can see almost 3/4 of the cases are in the males compared to the females. And the reason is very simple, that the males are mostly going out, not following the basic intricacies of common hygiene for stopping the disease, not washing their hands and with soap and water again and again, and not using the mask. They still believe that I'm the superhero and I will not get the disease. And these are the couple of the reasons because of that, the most of the males are getting the infection. Now, how this virus replicates? So, as I said, you have seen that how the virus looks like. This goes and binds with a ACE2 receptor, which is found onto the epithelial cells in the nasopharyngeal swab, and it attaches there. Immediately, the lysosomes uncoats it, and this nuclear protein, that is N protein, nucleoprotein, takes the RNA out, and this RNA starts its own replication because it has its own proteases, and then all these different proteins, which I said in the previous slides, they are all mRNA synthesized. They go for maturation at the endoplasmic reticulum, and then for maturation in Golgi. Everything goes in a vesicle, and that's how the exocytosis happens, and then the virus release, and that's how the virus is actually gets mature, and then the new virus is actually going into your sneezing and coughing. This also we have published now. Now, how this virus is transmitted? So most of us now know that the virus is mostly transmitted via the droplet containing the virus in the air, and these droplets land in nose, mouth, possibly lungs, and then you get the infection. The other is that if this droplet falls onto any object, might be telephone, or it can be a common place where a lot of people are there, or social crowding, or so on. But if you still keep 1 to 2 feet distance, then you can still manage that you should not get the disease. I just want to briefly tell about that. What is this droplet infection? So normally, most of the infections which go via air or by mouth, they have the 3 types: droplet, and droplet nuclei. So the drops is normally, which you might have seen in a movie, Main Hoon Na, when a physics teacher speaks. So a lot of sputum also gets out. So these are the drop infections, which normally go almost 1 feet to 2 feet. There is a droplet which are smaller than this, and that can go about 1 to 2 meters. And then there's a droplet nuclei which can go up to 6 meters. So that's how these infections transmit. And thank God this is a droplet. So it's still within 1 to 2 meters. If you make a safe distance, you may not get the disease. Now, how the transmission actually happens? It primarily through large particle like respiratory droplet. This requires close contact between the source and recipient persons, because droplet do not remain suspended in the air and generally travel a short distance, that is less than 6 feet. Contact with contaminated surface is another possible source of transmission, and all respiratory secretion on body fluid, including the diarrheal stool of the COVID-19 cases, can be considered as the potentially infectious. These are some of the common places which we get and touch, and that's how we normally get infections, including the common corridors and so many other areas. The kids are little more infectious because they are mostly asymptomatic, so they can transmit the disease beginning 1 day prior the symptoms develop and up to the 14 or more days since they become sick. This means that you may be able to pass on the COVID-19 to someone else before even you know that you are sick. So that's why it is very important when the kids are going out, you have to take an additional precautions. These kids can be mostly asymptomatic, but if they do become symptomatic, there might be a little longer duration of the contagiousness, so they can transmit the disease to the adults in a little faster way than the others. So that's why all these close contacts are supposed to be avoided. Now, how this causes the disease, that is called pathogenesis. So when somebody who is less than 6 feet sneezes or coughs in front of you, then the virus, if it is present in the mucus, that goes in your nose or nasopharyngeal thing, and then it goes to the trachea, and then it goes to the bronchus, and then eventually settles to bronchioles, where it activates the bronchial lymph nodes to swell, and then the alveolar macrophages starts making the mucus, and that mucus is not although very much common, but is still able to be sufficient enough to cause the sneezing and coughing. And then when you sneeze and cough, you again transmit the virus like this fellow has transmitted to you. So that's why it is very important to use the mask each and every time when you are talking to others. Now, once somebody who gets the virus, inside, as soon as the virus reaches, the cellular immune response gets activated. And as I said, the CD4 cells, they immediately take the activated helper cells, they immediately catch the virus. and this activated cytotoxic T cells try to kill the virus as early as possible. But the virus is also smart enough that also engulfs these cells. So that's why most of the patients with the COVID-19, the CD4 and CD8 loss has been very common. These cells eventually kill the virus. If they are successful, then you are in the bracket of that 63% which I said, and you might be asymptomatic but still got the disease and successfully eliminated. They also induces a couple of cytokines like interferon gamma and TNF alpha that kills the virus and infected epithelial cells. And they also send a message to the B lymphocytes where if they see this virus again, then this immediately makes the antibody secreting plasma cells, and that also helps the virus elimination. That's what people are saying nowadays, that the plasma donation saves the life, and that's pretty true. So that's why the people who have got, we are taking the plasma if they have the sufficient antibody. But the people who have the milder infection or asymptomatic, their antibodies are not sufficient enough to neutralize, and they might get infection again also. And most of the time it has been found that these antibodies are very short-lived, maybe 1 month to 2 months. So what are the symptoms or the clinical features? As I said, the incubation period, exact incubation period, we still do not know. We believe it is 2 to 14 days. Some people say 5 to 7 days. Infectious period, we are still not knowing that how long. And the estimated duration of the viral setting is based upon the infection, and it depends upon the viral titer in your body. And the general persons with the COVID-19 virus infection should be considered potentially infectious from 1 day before to 12 days following the illness onset. Onset means the time when the symptoms start. Now what happens, as I said, 60 to 70% patients, they normally get very mild disease and they get recovered, or they might be asymptomatic. The milder infections might have fever, fatigue and dry cough, whereas the moderate ones might be having itches and pains, runny nose, sore throat, shortness of breath and diarrhea, whereas in the critical cases, multi-organ failure can happen, and this also causes severe pneumonia and acute respiratory distress. So these are the cases which are less than 2 to 3% in India. Now this is the work which we have done from KGMU and in collaboration with various other doctors all over India. And what we have found that the incubation period is around 3 to 14 days with a median of around 5 days. Most of the patients will be in this phase. The prodromal conditions, they might have fever, cough, sore throat, arthralgia, myalgia, that means pain in muscles and bone, GI upset, so they might be having diarrhea, vomiting and abdominal pain. This happens in the day 1 and day 7, and hydroxychloroquine may be given at this stage. They might develop pneumonia if they have not been taken care, or if they are running here and there and haven't gone to the doctor. So then this might be fever, recurrent or persistent. They might be letharginous. There will be elevated CRP and down-regulated liver function test. The CXR feature of the pneumonia can also be seen. This happens mostly from day 8 to day 10, and these are the couple of medicines which can be given. If the treatment works, they might recover, or if there is a clinical deterioration, they might see hypoxia or progressive exertional dyspnea, that means सांस लेने में problem होना, and the shortness of breath. They can be increased in CRP, they can be decreased in the liver function, there can be saturation of the oxygen can be decreased, and this RR can also go up, suggesting these medicines can be given at this moment. If this situation is also not getting well, they might progress to shock or acute respiratory distress with multi-organ failure. And this is the condition where the cytokine storm gets up, and that's how the interleukin and Th2 gets significantly up, and this becomes mostly fatal. And most of the cases where we are seeing fatality, this treatment can also be tried. In children, what are the emergency signs? So children mostly, they have breathlessness, they have cyanosis. Cyanosis means the skin color starts becoming blue. They are not drinking enough fluids, not waking up or not interacting, being so irritable that the child does not want to be held. Flu-like symptoms improve, but then return with fever and worse cough, fever with rash. So these are the symptoms. If somebody sees, then they have to immediately rush to the hospitals. In adult, what are the emergency warning signs? There can be difficulty in breathing or shortness of breath, pain or pressure in the chest or abdomen, sudden dizziness, confusion, severe or persistent vomiting. If these symptoms happens, then immediately rush to the hospital. As most of these symptoms which we are saying, they are also quite overlapping with the common cold, flu and allergies. But this is a comparative chart for differentiating among the other diseases. And any good doctor in the OPD can decide whether he should get you tested for COVID-19 or not based on this particular differentiation charts. Now, what are the patients who died? What kind of complications they had? Most of the patients who were the fatal infections we have seen, they had the upper respiratory tract diseases, sinusitis, otitis media. They can have lower respiratory tract diseases like pneumonia, bronchitis, bronchiolitis, or asthma. They might be having cardiomyocarditis or pericarditis. They can be musculoskeletal like myositis or rhabdomyolysis. There can be neurological complications like acute and post-infectious encephalopathy, encephalitis, febrile seizures, and status epilepticus. They might have toxic shock syndrome when the cytokines are secreted much more than the required, and the secondary bacterial pneumonia with or without sepsis can also happen. That may cause a fatal infections. These are some of the age groups which are at the higher risks. Children less than 5 years and the persons aged 65 years or older. Children who are on a long-term aspirin therapy, because this causes a chance to have a race syndrome. That means they might have a chance of multi-organ failure when this happens. Pregnant ladies, adult and children with chronic pulmonary, cardiovascular, hepatic, hematological, neurological, neuromuscular, or metabolic disorders, adults and children who have immunosuppression, like the people who are on the treatment of HIV, HPV, HCV, and so on, residents of nursing homes and chronic care facilities, they are also at the higher risk of getting the infections. So how we diagnose? As before diagnosing, we have the very clear-cut definitions to whom to diagnose. So a suspected case can be a patient with acute respiratory illness. That means a fever and at least one sign or symptom of respiratory disease, which I said earlier, and with no etiology that fully explains the clinical presentation, and the history of travel to a residence or in a country where these cases have been reported in last 14 days. A patient with any acute respiratory illness can also be seen if there is a confirmed or probable COVID-19 cases in their locality or vicinity has been seen, or a patient with severe acute respiratory infection and requiring hospitalization with no etiology fully explaining any other clinical presentation. So these are the situations which is suspected cases. A probable case may be a suspect case for whom testing for COVID-19 is inconclusive, or a suspect case for whom testing could not be performed for any reason. And a confirmed case will be when we do the RT-PCR in the laboratory, and when after all this is done, and if the RT-PCR is positive, even if you do not have any symptoms, you will be treated as a positive case. Now, these are certain equipments which we use to collect the nasopharyngeal swab or throat swab and so on, and then immediately we put into the virus transmission media and then send to the concerned lab. What we collect, so from an ambulatory patient, that means the patient who can come to the clinic and can go back to home, we collect the nasal swab, throat swab, and immediately put into the VTM. And then we have the intubated patients, that means the patient who come with a coma or some kind of not consciousness, we collect the lower respiratory aspirate. We may also collect posterior pharyngeal swab, nasal washes, acute and convalescent serum, just to see the antibody titers in these patients. So then what is the treatment? As we know, there's no treatment or cure. Scientists across the world are working to find out the cure and create the vaccine and drugs. Only the clinical management is possible at the moment. What we do, Infection control, we isolate the patients in the isolation, implement infection control precaution, personal protective equipments for the healthcare workers and family members. If the oxygen is really low, we provide the ICU treatment where we administer the oxygen, mechanical ventilation or respiratory failure can be taken care. We also give the medication, and corticosteroid treatment is normally not recommended, but if required, can also be given. Now, there are certain other treatments which is very commonly given: IV fluids, parenteral nutrition, oxygen therapy or ventilatory support, antibiotics for secondary infection if it is required, vasopressor for shock. Paracetamol is prescribed for fever, myalgia, and headache. Patient is advised to drink plenty of fluids. This is very important because this dilutes the virus in your blood, and more water or plenty fluid if you take, then the viral titer can be going down and then you can recover fast. Avoid smoking because this makes you immunocompromised. For sore throat, you can take the short course of topical decongestant, saline nasal drops. Throat lozenges, steam inhalation may be beneficial. When a lot of Ministry of Ayush has given a couple of guidelines where the curcumin and nimbin and so on, we have also done these tests in the clinical trials also is going on, where we have found they're quite effective. The salicylates like aspirin is strongly contraindicated in these patients, and patients due to its potential cause of causing the Ray's syndrome, that is a multi-organ failure. And monitoring of this clinical and radiological evidence for the lower respiratory tract infection and for hypoxia is also very important, and that's why we ask them to be in the hospital. Now, is there a vaccine? All of us know, yes, there's no vaccine available for this particular at this moment. The known influenza vaccine which is in the market is not going to work for this COVID-19. Any vaccine normally takes 14 to 18 months as per the protocol. So we do not have any chance of getting the vaccine before the end of this year. Now, there's a lot of R&D work is going on. It is focusing in test, treat, and prevent. So here we are having various short-term and long-term goals for testing. We have various identifications and developing the therapies for the treatment. We are also developing high efficacy for the community protection, safe in humans, active against COVID-19, quickly manufactured hundreds of millions, if not billions of doses, and that's how we prevent. Now, if you see, worldwide, around 41 regulatory authorized diagnostic tests are going on for developing the novel diagnostics. There are 23 assets in the human clinical trials are going on. There's around 5 clinical trials from the vaccines are also at the leading stage. And out of this FDA approved are around 20 in the diagnostics, and most of them, if you see, are focusing for 12 plus hours of the reporting. There is 2 to 8 hours of reporting. The 23 of them are actually working for this. 7 researchers are where the report can be given in less than 1 hour. When in KGMU also we try to give the report in a day as early as possible for the patients. Now, if you see, most of the treatments are, you see there are 2 failed. There have been 1 emergency use. There have been 1 phase 4 trial is going on, which is still into the risk and benefit and best use. There are the 5 phase 3 studies are going on, 4 phase 2 and 3, and so on. Similarly, for the vaccine, we have 3 DNA-based vaccine, 1 inactivated, 1 live attenuated, 5 non-replicating viral vectors, 15 protein subunits, 3 replicating viral vector, 7 RNA-based, 1 VLP-based, and 5 are unknown or they have not disclosed yet. So these are the 41. They are in the preclinical stages of the development. Now, these are the couple of tests which, the couple of the drugs which have been already, the 2 of them have been failed, the 1 which is in phase 4, and so on. The couple of these things are still going, but still we do not have a very clear-cut cure available with us that suggests us that the prevention is at this the best possible way. That means regularly and thoroughly clean your hands with soap and water. Maintain at least 1 meter distance between yourself and anyone who is coughing or sneezing. Avoid touching eyes, nose, and mouth again and again. Stay home if you feel unwell. If you have a fever, cough, or difficulty breathing, seek medical attention and call in advance. Follow the direction of a local health authority. Arogya Setu, I'm sure all of you might be having in your mobile. You can follow them. Stay informed on the latest development about this COVID-19. All these apps are giving the recent developments. Keep up to date on the latest COVID-19 hotspots in your city and local areas. This app also gives that information also. And so what you should do, you should cover your mouth and nose with a handkerchief or tissue while coughing and sneezing. Wash your hand every time after coughing or sneezing. And when you touch something, avoid crowded places. Do stay at home if you are infected or having flu-like illness. Keep at least an arm distance from the people affected, or even otherwise also. Social distancing is very important. Sleep well, stay physically active, and effectively manage stress. Stress makes you more immunocompromised. Drink plenty of water and eat nutritious food. What you should not do, that you should not shake hands, hug or kiss socially, or use other contact greetings. Don't take self-medications. Do not spit outdoors. One of the biggest problems I see in most of the cities in India. Don't smoke because it makes you immunocompromised. And do not use aspirin in children, even in adults. And frankly telling, don't do the self-medication. And if you are sick, make sure that you wear the mask properly. Even if you are not sick, still it is better to wear the mask. One of the important things that the masks which have any kind of opening outside, they should not be worn because they have a risk of transmitting the air from you to the people who are not having that kind of mask. Now, washing of your hands with soap and water is the best precaution, and if that is not available, then alcohol-based sanitizers can be used. Again, I am reiterating that washing of your hands with soap and water is the best precaution. If that is not available, then alcohol-based sanitizers should be used. Alcohol-based sanitizers are not for the primary uses. So when there is a lot of hue and cry that there's not the sanitizer available in the market and this and that, please do not worry. Wash your hands with soap and water as much as possible. The washing of your hands with soap and water should be done for at least 30 seconds. Now, the new recommendation says 30 to 40 seconds. And if that is not available, then alcohol-based disposable hand wipes can be used. And if using gel rub, make sure that your gel gets dry. A lot of people are using the liquid, and then after becoming dry, they are still touching something. So that's of no use. Your hands has to be completely dry. Even if it is taking few minutes, that has to be done. So what you should do, how to wash your hands when you're doing it for 30 seconds. So first you put the soap on your hand, then palm to palm, back of your hands, then fingers interlaced, then thumbs, then fingernails, then wrist, then rinse your hands, and then dry your hands. These are the 9 steps. Everyone has to do it for at least 30 to 40 seconds. If you feel that you have done it little early, then you can repeat it at least twice and thrice. Make sure that wash your hands with soap and water. Now, most of the important thing for us is the prevention of COVID-19, and that has 3 components. Prevention in humans, this flattening of curve, which you might be heard from the Prime Minister's various talks also, that the flattening of curve is required. So prevention in humans, prevention of transmission to humans, and prevention of its spread among humans. So these are the important things. What we can do, we have to follow 4 P's, that is plan, take time, that who is the vulnerable population in your vicinity, who is the family members in the community who might get the infection, where they are going, whether there is enough arrangement at the school, university and child care, and whether the work, business and government can be taken care when they are getting the infections, whether they are able to handle it. Prepare yourself for caring for the self, family and community. So you should know where to get for the medications, where to go for the medications and health supplies. Whether the school closing arrangements are there, fortunately now all the e-classes are going on. If you are putting your kid in a child care place, make sure that there's nobody who is having symptoms. And if there is somebody, then do you have an alternative arrangement? And when you're not well, you don't feel to go to the shops. So non-perishable food and water has to be available with you. You should also make sure that you are vaccinated against the diseases for which the vaccines are available. If you are at a high risk, cover your cough. You can see this has been one of the training given to all the schools also, that use your arm when you are sneezing and coughing. Wash your hands with soap and water. If it is not available, then use the alcohol-based sanitizer. Prevent and manage any chronic disease if you have. That is very important if you want to be safe. And protect yourself. If you know the symptoms, and you should know when to go to the hospital, you should also know when to see to your doctor. You should protect vulnerable population in your family members, like senior citizens or children or somebody who is not wearing the mask. Tell them, and breastfeed your baby even if you are not well. So what we have seen is, to stop the pandemic, we have to educate the population, to the masses. And the masses means demos. Demos means the public. So what we have seen, that when we make the people more educated, the panic can be stopped. So make the people more and more educated. Whatever the information I have given, please pass on to your colleagues, to your friends and neighbors, so that the panic can be stopped. We can still manage the disease in a much better and broader way as we thought of. Now, these are the couple of the numbers given by the government of India. We always say stop the infection and be the hero. You can note down these numbers. These are available 24/7. In case of emergency, you do not have to call somebody personally. This is a number called +91 90131 51515. Somebody will respond you immediately. There is a toll-free number, that is 1075. You can directly call to the 01123978046. There is an IDSP doctor will be available. There's another toll-free number, that is 1800-112-545. These are the couple of numbers. The first number which I have shown you, even available onto the WhatsApp also, so you can directly send a message and you can get not only this number, also gives you what are the hottest spots in your area and where to go, what to do, and in case of any confusion, directly call to this number. And a lot of people say, I haven't touched anybody, so I haven't have any problem in my hand. You see, this is one of the picture of the hand of one fellow. You see how many infections he is carrying. So darker the red color are the number of infections you are carrying in your hand. So washing of your hands with soap and water is the best precaution. And I also suggest that the people who are using the mask, please make sure that your mask is also neat and clean. Change it at least if it is daily changing basis, or at least wash every day, that if you're using the washable ones. Make sure that these things are very neat and clean. A lot of people are asking me that, sir, since a long time we are not having any way of greeting Caesar, because we are saying do not shake hands, do not kiss, don't shake and meet and so on. So this is just on a lighter note, that you can do the long distance wave, somebody just to say wave hands. You can do the elbow bump without touching the hands. It's a really, really a very unique virus which just passes on by touch, but not by doing any long distance wave. You can wear the sanitary gloves if you really feel to touch somebody. If there's a professor and you are a junior faculty, you can do the bow like this, and two HODs can do this bump on. So these are some novel ways of greetings which we have to learn in the times to come. Beyond this lighter note, you might have heard that these are the two newer species where also the COVID-19 has been reported. And we are not even able to handle the one at this moment. We are going to get another pandemic, and are we ready for another pandemic? So we have to make sure that the people who have the animals and pets, that we should not transmit the diseases to them. When you are not well, you can also transmit the diseases to those animals as well. And finally, I'm really thankful to the NASI and the Regional Science Center for giving me this opportunity. This all work which we have done is actually the outcome that no challenge too big, no problem too complex. That is what inspires us when we work in biosafety level 3 or 4 facilities. And these are a couple of books which are available onto the net. And this is one of the books, Coronavirus Disease 2019. World's first textbook also came from the KGMU Lucknow, written by several of the doctors from all over India and abroad. And this is also available. And as a part of the return gift to all of you who have been very patiently hearing my talk, I would like to give this book, the e-copy, free of cost to all of you. And I'll send this link to the Dr. Mishra and Dr. Tripathi, and then he will forward to you this link and you can download this book. So thank you very much. Although this book is also available onto the Amazon, where it is costing around 20,000 rupees. And as a gift, I'm giving this as a token of my appreciation to all of you. Thank you very much for giving me this time. And I'll be very happy to answer any questions if you have. Thank you.
Now this session is open for questions, please, or for any discussions.
May I?
Sure, please.
Thank you so much. Good evening, Dr. Shailendra. How are you?
I'm good.
This is Dr. Taru from IVRI.
Hello, madam. How are you?
Good. Thank you very much for a very nice talk. I just have so many things there, but the last thing first. As you said, the pets and the tigers. So for everybody, I believe there are two opinions, very clear opinion. One, on 23rd of April 2020, it came that 3 of the tigress and 1 lioness positive from New York Zoo. But later there were 2 school of thoughts. And eventually, people who are following the WHO pandemic updates, I'm sure Dr. Shailendra might agree with me that WHO has called that when people were asking that do pets have the COVID or can they really be the carrier, I believe it came as the WHO says it's a myth. So these are the 2 things which I have been following very carefully. And at our Indian Veterinary Research Institute, our Wildlife Center is very particularly taking care of this. Until date, we haven't yet come across any of the cases which is tested positive for COVID-19. We are also a COVID testing center for the information of the esteemed fellowships for this seminar. This is what I just wanted to submit. Thank you for the chance. And if permitted, I have a small, very quick question. So may I go ahead if permitted?
Yes, ma'am. Please ask.
Okay, Dr. Shailendra, about the plasma therapy, so as we have been hearing, like immunity lasts for limited time and more reports has come. The other day we heard Dr. Soumya Swaminathan as well, and the WHO experts they invite. They say like 60 days to 80 days. So I want to know from you, in the Indian scenario, what is your take at it? Thank you.
See, what we have seen is that most of the patients who are having the mild infections, the antibody is not long-lived. So normally the same thing which you have seen 60 to 80 days, which we are also seeing. The long-term, so any antibody which is present for even 5 to 6 months, we say short-term. Any antibody which is present for more than 2 years, we say long-term. So frankly speaking, even whatever data which we have till date, because the disease itself is not more than 5 to 6 months. So we haven't seen any long-term availability of the...
Yeah. So in that case, do you really recommend having the plasma from the symptomatic people rather than having it from asymptomatic people?
Actually, the plasma is taken based upon the antibody present, and most of the cases where we are taking plasma is all the symptomatic. We have been to, so the patients who have either the severe or the moderate at least. And again, the titer has to be more than 4-fold up. So if that is not there, we are not taking that plasma.
Thank you so much. Appreciated. Thank you for the presentation.
Thank you, ma'am.
Hello, sir.
Hello.
Hello. Sir, may I ask question? Hello.
Yeah.
Yes, please.
Yes, please.
Sir, I want. Yes, sir, I want. Is there
Can you introduce yourself?
Sir, myself Verma. I am a assistant professor biotechnology, SMTD college.
Okay.
So,
We are facing
Voice
audio
is cutting.
problem.
Voice is cutting.
Your voice is not coming.
Voice is cutting.
hello. Oh, hello. Can you listen me? Hello, sir. Hello. Hello. Sir. Hello.
Professor Tandon, there is some problem.
Yes.
Hello. Hello.
Maybe you can write your question in the chat box.
Okay, sir. I am just.
And may I request that everyone other than the speaker and the person who is asking the question mute their mics, because that causes echo.
Yeah, I have a question.
Dr. Sahab, I have raised two questions in chat box. Would you be kind enough to reply them?
You can speak also because you are well audible.
Yes.
Yeah, I just wanted to know that one thing is that this Corona series virus, I heard that it was once spread in 2002 in the series first. So most of the proteomics and genomics was similar to. So what were the reason in last 18 years we could not develop a successful vaccine on that very line?
See, normally what happens na Hindi में कहावत है ना जाके पैर न फटे बेवाई हो के जाने पीर
जी
पर आई.
जी.
That was limited to China. So people thought that we should not be bothering about this. So most of the research which was there, that was limited in China when we have seen the earlier SARS, and that was contained over there. We haven't seen this. Even this time also, till the month of March, we were not even sensitized that we have to be very careful when we are going to play the Holi. I don't know how many of you have seen my interviews in the month of January and February when I said, please don't play Holi. So that's the level of sensitization. We haven't bothered. Now we are bothered and we're looking everything in desperately. So whatever is coming up, we are saying that the vaccine will be available next month. The vaccine will be available next week. It is every time I'm saying this is not a Domino's pizza which you order and it will come in 30 minutes. It is not like that. There's a whole protocol which requires 12 to 18 months. It will take 12 to 18 months, even the fastest one. But these are RNA viruses. And as I said, the A virus changes to B virus changes to C virus. You might have seen today's interview of the President of America. He has already mentioned that you have to take multiple doses of or multiple shots of even if the vaccine is available for the COVID-19. So these are all the limitations which we have to unfortunately face, but there's no other alternative at this moment with us.
Thank you very much.
Yeah, can I ask one question?
Please, sir, please.
Yeah, thank you. My name is Shekhar Malik. I am speaking from NBRI. I'm a plant biologist. So many of my queries will seem to you a very naive and very general in nature. It may not be very specific. My question to you is that it's based upon a general observation that why only human beings are getting infected and why not animals? What is your experience about it, and how much you have come across that the animals are also getting affected? Given this particular scenario, does it mean that only human beings are vulnerable, or alternatively, animals have certain mechanism by which they can withstand that? Maybe they have antibodies present in their blood plasma. For example, if you are saying that the point of origin is bat, is it possible that the bats are surviving with this virus, having this mechanism of overcoming the effect of the virus? This was my first question. Second question is that
Your first
the
question
vaccine-
already has 5 questions, so let me answer your first question first.
Okay, please.
So your first question was that whether the animals have or not. The coronaviruses, even before it was known to humans, it is known to the animals only. And they are natural carriers for the coronaviruses. Normally, they do not transmit the infections to the humans unless or until somebody who has been very much exposed, like feline or canine, those kind of ways. But normally they are not. Or even if they do transmit the infection, they are not fatal or they are not even serious at all. We are not even asking them to use the paracetamol when we come to know that there is any animal coronavirus has been transmitted to the humans. But there has been a lot of work done by the IVRI. Taru madam is already here. They have already seen a lot of coronaviruses in the animals. So it is not like that the animals are not getting it. Animals do get. Now the question is whether they are getting the COVID-19. Yes, the bat is already seen in the COVID-19 strain in the bats also. Bats are known to have, or they are known to have the carriers for more than 2,000 types of pathogens till date. So how they actually survive, what is the evolutionary mechanism, that's another area of research. People are already working on that. And now the bat research has taken a very big leap in terms of understanding that why the bats, in spite of having all these kind of infections, do not show any symptoms or they remain asymptomatic.
Okay, can I continue with my second question, if you may allow?
Yes.
Yeah, I'd like to get your opinion about the vaccine being developed by this biotech. What is your opinion about it? Secondly, I will also invite your opinion about, see, given the incidences of these viral diseases which are very prevalent and it is actually costing several lives. So what do you think, in your opinion, that apart from bacterial diseases, we should have a viral disease institute developing and doing research to develop vaccines? What is your opinion? I would like to know.
No, can you repeat your question once again?
My question was that, first question is that in the scenario of vaccine development of COVID virus, India as well as the Oxford University have taken some lead. Even Bharat Biotech, the company, has come out with a vaccine saying that it will take another 1 year to come out with the first, to get it certified. So my question to you, to get an opinion, it's not a question, it's your opinion. I'd like to get your opinion. How much confidence do you have, given the Indian research scenario and the Indian research confidence, given this research confidence in India? So how much confidence do you have for the vaccine which is being developed in India? And second part was that, given the number of lives which are being claimed by the viral disease, so is it not the time that we should have several viral research institutes for developing vaccines in this life, for this life?
So the first question, that whether we are confident about the vaccine developed by India.
That's right.
I am quite confident. In India, this is not the dearth of any talent who cannot make the vaccine, including it can be done in KGMU, Lucknow itself. I can put this on, be done. Only the thing is the willingness. Nothing is done for free. You need to put a lot of money behind the research. Everybody is asking low-hanging fruits, long-hanging, what you are getting in CSIR, these two words. How can be a vaccine a low-hanging fruit? We cannot give you something in 1 month. You won't believe. I have been asked by several secretaries, can you give me a vaccine in 30 days? And I have to clearly say, no, this is not possible. Now, just for waiting that 1 month, we had already crossed 7 months. And still, we have not reached to that level that where the vaccine is. What Bharat Biotech is doing for their own personal sake. It is not going to be a free of the cost vaccine. So any company will do that. When a company can do, why can't an organization can do? But then this has to be taken care by the policymakers. are the people who are at the higher ups. They have to take this issue that yes, this is the work India has to do, and we do not want any private setups and this kind of thing. Now, the second question is whether the organizations for the virus research has to be. Yes, they have to be. And if several of the senior fellows in this meeting might be knowing, Dr. Lalji Singh already tried to make the BSL-4 facility at CCMB Hyderabad. But then a lot of renowned scientists of India who are also the fellow of all the academies, they deliberately closed that. So it simply shows that the long unsightedness or short-sightedness of the experts sitting in the different panels. They do not want to. So people, unless or until they have a fear in the mind, no, I cannot do this thing, India cannot make a vaccine, India cannot handle the virus, till then it is not possible. But yes, the day they have, I have been specifically trained in BSL-4 from the CDC and the Canadian Health Science Center, and I have passed the examination. It is not just by training. But then where these talents can be used, if somebody is really willing to, that can be actually used. Why we are not thinking of making BSL-4 facilities in India? There's only one facility, that is in NIV Pune, that's it. So we have to critically analyze, and there needs to be people who can actually look into seriously, and the younger youth has to be taken at the front, okay, you have to do this. It can be done.
Thank you, sir.
May I ask a question, please?
Yes, ma'am.
Yes,
I am.
you have written in the chat box also.
Yeah. I am Shuchitra Banerjee from CSR CMAP Lucknow. I have a question that how much possibility are there to get the disease transmitted through vegetables, fruits, newspaper, and moreover all the online things that are coming nowadays. So what are the chances of getting the disease transmitted through these channels?
See, normally anything coming from outside has equal risk as you are going outside. So what we are suggesting, because we cannot stop a lot of things, that if the things, you can keep it for 72 hours at the room temperature, whether it is a vegetable, whether it's a grocery or anything, then at least you can protect yourself from getting any infection. Nothing is going to survive at the room temperature, considering the conditions in India at the moment. So that is one of the way. If really you want to use it immediately, and if you are very much desperate, like for example, the milk packets and so on, you can keep it in the running water with a small baking soda if you add in this, and that's it. You are again, clear. It's just like a bleaching your surface, which you are actually, especially the products which are in a cold chain. These are the two ways which we are suggesting the people. Even a lot of vegetables which you are using green, like coriander or ginger and so on, that also you can just wash with a small baking powder and you can reuse it again.
Is it true that if we keep it in the sunlight, then also it gets disinfected?
No, no, we have never seen an impact of sun, at least till date. It was thought earlier that when the summer will come, the cases will go down. Nothing of that is happening. So sun has nothing to do with this.
And I have my last question with regard to the currencies, because we are very skeptic about changing the currency and giving it to somebody and getting back the. So what are your suggestions for that?
See, currency is always highest infected, otherwise also, not with the COVID, but a lot of bacteria is also there. The simple thing is, whenever you change the currency, either give or take, wash your hands with soap and water, and that's the best precaution.
What my son is doing, he is ironing the currency notes.
Not required, because every time you can't do that. So
Exactly.
the best is wash your hands instead of washing your currency.
Okay. Thank you very much. Excellent, excellent presentation.
Thank you, ma'am.
Can I ask a question, please?
Yes, sir.
This is Professor Ramnaresh Tripathi from HBTU Conference. Actually, I am a mathematical modeler. I must thank you for the nice presentation regarding the epidemiological aspects of this. My question is, what is the probability of transmitting the virus vertically? Number one.
What is the
probability of transmitting the virus vertically? Means mother to child transmission. Secondly, When there were little cases, we had nationwide lockdown. And now when the cases are rising exponentially, there is an unlocked phase 2. And the cases are continuously increasing. Can you comment on that?
See, first question with what are the chances of the mother to infant transmission?
Right.
Till date, we have not seen any cases where the mother to infant transmission has been recorded, or you say transplacental transmission of coronavirus has been seen in for COVID-19. Second question is when the cases are high, we have unlockdown 2 or all those kind of things. It's a very tricky question actually, and unfortunately, there's no option. If we do not open, then there is a big issue of the livelihood of a lot of people who are actually the 60 to 70% of the population who is actually earning their livelihood on daily basis. So there was no other option to unless or until you open it. However, there have been a couple of models, like for example, we are suggesting the government to close it on the weekends, which has been recently accepted. We are also suggesting the government to open the market of one area on one day and keep the remaining city closed. But the problem with that is the people who are coming from that area for the industrial purposes, they are not able to reach to their destination. So that is one of the place which we are getting stuck at how to actually materialize. But yes, if it is required further, in several developed countries also, the lockdown 2 has also been initiated after the opening for a couple of months, then again the lockdown has been done. So that scenario can also arise if the situation gets worse.
Doctor, that means are we heading towards the community transmission?
May I have a question, please?
Yes, yes, madam.
I'm Veena Chandan, an RC senior scientist at BioPark. I have a question that with these zero testing going on these days, what are the chances of cross reactivity? Are these very COVID-19 specific, or they can be positive cases for other flus?
Ma'am, can you repeat your question once again?
My question is that with zero testing going on nowadays, what are the chances of these tests being cross-reactive for other flu viruses, or they are very specific for COVID-19 virus?
See, the tests which are for the sero positivity, they are mostly based upon the IgG and IgM, and they have around 30% false positivity. And that is pretty high, but because we do not have RT-PCR available for everybody, which is costing around 2,500, so a lot of people are going for that. So what we are doing is if somebody comes positive in that particular test, we are again testing these patients with the RT-PCR, and if the RT-PCR test is positive, as I showed in my slides also, then only we say it's positive, otherwise we say it's a false negative or it's a false positive.
Because a high number of asymptomatic cases coming, showing positive in testing, I was wondering they could be having antibodies for common flu as well.
Yes, they do have antibodies, but most of these antibodies, as Dr. Taru has already said, they are not very long-lived. So that means, like what we say, the repeated assault of our T cells and B cells by this particular pathogen that has been noticed. But that is not going to be a very preventive at this moment, whatever we have seen. That means a person who might have even the low level of antibodies might also get the infection at the later stage.
Thank you.
Thank you, ma'am.
Sir, myself, Dr. Sundar Chaudhary. I have two questions. I wish to know about the temperature where COVID-19 can survive? And second question, can we use saline water for treatment of vegetables and fruits before taking?
Sir, can you repeat your question once again?
Sir, I wish to know about the temperature range where COVID-19 can survive. Temperature range.
See, normally, whatever the data coming from worldwide, the virus is it's an enveloped virus. So normally the enveloped viruses are quite resistant to the temperatures.
Okay.
And even not only the temperatures, but also with a lot of abrupt conditions which we see. In India-like situation, if you talk about, we have seen the summers also where the temperature has gone almost up to 50 degrees centigrade.
Yes.
And we have seen the winters also where the temperature has gone up to almost -2 degrees centigrade, and still the virus sustained. So what we have seen that it is not quite dependent on the temperature at the moment. However, most of the studies which initiated the temperature dependency of the virus has been inconclusive.
Okay, sir. And my second question is we can use saline water for treating these vegetables and fruits.
Saline water has not been shown very effective. Only the baking powder we are seeing, because that is sodium bicarbonate, and that actually makes the carbolic acid indirectly. So that's why carbonic acid helps in killing the virus. So it makes a more acidic pH. So that's how.
Okay. Thank you.
Thank you.
Hello, sir. Hello,
Yes.
sir.
Yes.
Now I am audible.
Yes. Yes.
Sir, is CRISPR's technology have any chance to kill the viruses? Or is going on in the CRISPR technology? As these viruses have the conserved RNA sequences, and by CRISPR technology, it can, as it is a guide RNA, so it can cut the RNA, and it may be a powerful treatment in future.
Can you speak? Can you
is
repeat your question?
Sir, is CRISPR's technology
Which technology?
to kill these viruses? CRISPR's technology.
CRISPR technology. CRISPR technology?
Yes, sir, yes.
I think Taru ma'am can answer much better than me about the CRISPR technology. See, normally these technologies are gene tool based, and for these kind of viruses which are not actually going to integrate in your genome, the CRISPR is not going to be a very good method.
Yeah. I think Dr. Shailendra already told. See, this is a RNA virus that we have to keep in mind at the base. And then we have to talk about it. Right now, what it happens when the spike protein comes, they befool the cells, and physiologically, they really are befooling the cytosolic agents. This is what is happening.
Okay.
And it's replicating. That is the whole crux. CRISPR is a good idea, but not for the, I believe for COVID-19, it's pretty tricky, you know.
Yes.
Thank you.
Okay. Thank you. Thank you.
Can I have one last question, please? Thank you. I think we have had quite a long session. So now this is the time to deliver the vote of thanks.
Thank you, sir.
Myself, on behalf of Regional Science City Lucknow and NASI Lucknow chapter, express my gratitude to Professor Shailendra Kumar Saxena for delivering such a clear, interesting, and enlightening talk. We feel much informed and are in a better position now to understand this pandemic and its possible solutions and precautions which are to be taken. Also, we are able to come out of the infodemics on this topic, which had been puzzling our minds since very, very long, over this long period of time, since we have had this COVID invading the India. I'm thankful to Padma Shri Professor Pramod Tandon sir for giving us this opportunity to jointly host this webinar. I extend thanks to Professor R.D. Tripathi for coordinating so well, for organizing this event so successfully. And above all, I thank all the distinguished guests who took time for this webinar, and they made it, their presence really, in fact, made it a grand success. And your encouragement has really prompted us to bring more of such kind of webinars jointly in near future as well. So thank you very, very much, all of you. Stay safe and stay healthy. Thank you.
Thank you very much.
Thank you.
Thank you.
Thank you. Thank you, Dr. Shailendra. Namaste.
Thank you.
Thank you,
Yes.
Professor Saxena and organizers.
Thank you so much.
Thank you so much.
Thank you, sir.
Thanks.
We will meet you very soon again.
Stay
Thank
safe.
you.